webinar on peer respites as a voluntary alternative to the emergency department and other crisis services. This is the fourth of our crisis response virtual learning community webinar. I'm Dan Abreu, and I'll be your moderator for this webinar. The views and opinions and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Substance Abuse and Mental Health Services Administration or the U.S. Department of Health and Human Services. So, a couple of housekeeping items. There is a chat box down at the bottom corner of your screen, and throughout the presentation, feel free to enter questions there as you wish. At the end of the presentation, we will try to address as many of those questions as time permits. Also, this webinar is being recorded, so we ask, one, that you mute your phones, and please do not put your phones on hold so as to spare us from music. The Gaines TA Center has arranged for live captioning of today's webinar to enhance accessibility. To view live captioning, select the Accept button in the multimedia pod located in the lower right-hand corner of your WebEx screen. You can change the color contrast of the live caption pod to suit your needs, and we recommend selecting the high contrast style for best visibility. Before I introduce our panel, following this webinar, we will host a discussion group to allow more in-depth discussion with our presenters. Please note, though, that the participation in the discussion group will require you to terminate your computer and phone connections to this webinar. A new web link and phone number will be provided at the conclusion of this webinar to join the discussion group. Over the past 40 years, peer-run services and agencies have evolved in scope and as a profession. Peer services are being infused in programs across the sequential intercept model, from crisis work through the courts and jails into community supervision. In this crisis response webinar series, we have highlighted crisis triage units, mobile crisis teams, and law enforcement crisis co-response. And in each of the webinars, the importance of peer services and support was highlighted. Today, our focus is on peer respite programs and their contribution to the continuum of crisis care in communities. We have three exceptional presenters with you today, and our first that I will introduce is Dr. Bevan Croft. She is a research associate at the Human Services Research Institute in Massachusetts. She conducts research in the areas of self-direction, self-determination, peer respite, and crisis alternatives in state and county behavioral health system planning. She is the co-director of the National Center on Advancing Person-Centered Practices and Systems. She is also the principal investigator of a multi-state demonstration and evaluation of self-direction in behavioral health, funded by the Robert Lloyd Johnson Foundation. She is also the former project director of an evaluation of the second-story peer-run respite program in Santa Cruz, California, one of the first peer respites in the United States, and provides evaluation-related technical assistance to peer-run organizations working to develop peer respite in their communities. Casey Moyer is the executive director of the Mental Health Association of Nebraska. She has been instrumental in developing and implementing the largest peer-run organization in Nebraska, currently employing 48 peer specialists. She has significantly expanded peer services over the past 15 years, including Peers in Supported Employment, the Mental Health Emergency Department, respite houses, law enforcement referral and response programs, public schools, county jails, and state correctional facilities. She has extensive experience in hiring, training, and maintaining peer staff retention, many of the peers having 6 to 15 years of employment with the Mental Health Association. She has worked with the Nebraska Department of State Corrections, the Nebraska Parole Administration, and Nebraska State Probation. to develop and implement peer-operated reentry services. And our last presenter is Dr. Kirsten Vincent. She has worked in the health and human services field for over 26 years, having started her career with the Office for People with Developmental Disabilities. She transitioned into working solely in the mental health field after discovering peer services and her passion for supporting others with peer services through her own personal struggles with mental health. She serves as interim CEO of Housing Options Made Easy in New York State after joining the organization in 2015 to write the program for their short-term peer-run crisis respites and warm lines. At this point, I'm going to turn the webinar over to Dr. Croft to provide an overview of peer respites. Evan?
Hi, everybody, and thanks, Dan. I'm pleased to be here telling you about my work with peer respites. What I'm really hoping to do is just give everyone here an overview, really just to present a definition of peer respites, to describe, the state of peer respites in the United States, and then I will speak to the peer respite research that is out there, drawing from my own research and that of my colleagues. And it'll be, Casey and Kirsten who really tell you, and describe their experience on the ground. So hopefully this will give some context to what Casey and Kirsten will cover later. Throughout my few slides I've inserted a few quotes that are from a paper that I recently published with my colleagues, Leisha Ostrow and Ann Weaver, presenting the results of the qualitative portion of the study that we did at the Santa Cruz Second Story Peer Respite, where we interviewed peer respite guests over a 4-year period about their experience of peer respite. So I thought that might give you a sense of what it feels like from the perspective of guests. And guest is the term that I'll be using to describe people who use peer respites. So this guest said, before I was here, I was just spinning and spinning and spinning. Peer respite staff have given me a new perspective to try to work towards not doing the same thing over and over, changing and really accepting my symptoms as they come up and being able to work through them and not have to do the same thing over, go to the same place. And in this case, this person was referring to going to the hospital emergency room over and over again, and I'll touch on that in just a moment. I want to acknowledge that really the bulk of this work has been led by my dear colleague, Leisha Ostrow of Live and Learn Inc. And she hosts the website peerrespite.com, which is really a nice resource. It's a directory of peer respites in the U.S. There is a guidebook for peer respite self-evaluation that Leisha and I created that's really meant to empower peer-run organizations to use data and self-evaluation to track their impact and to shape their programs. We also have the website also has a number of different versions of the Peer Respite Essential Features Survey, which really surveys respites across the country so we can all get a better sense of what they look like, how they're funded, how they're staffed, et cetera. And then there's a research repository too. So it's a great resource to check out if you're interested in learning more about respite. So what is a peer respite? It is voluntary. It's a home-like environment. All of the staff who work at peer respites, including the leadership, are people who themselves have lived experience of using the behavioral health system, experiencing extreme states, having life-disrupting mental health-related experiences. So people who've been there in one way or another. There are between 2 and 10 people that they can accommodate, with an average of 4 across the respites in the U.S. And the average length of stay at peer respites is 5 days, although in many respites you can stay up to 2 weeks or something like that. And most of the funding for peer respites comes from state, county, or local revenue, such as funded through the Behavioral Health Authority or through state grants. they are based on the premise, and the quote that I read a moment ago gets to this, that people can avoid the use of psychiatric emergency services, so the emergency room, inpatient hospitalization, if they have something voluntary that's available to them in the community. So they, you go to a peer respite to avert the need for something more life-disrupting like an ER visit or an inpatient hospital stay. One peer respite guest, speaking to the peer support aspect of this, said there's a profound respect for your ability to know what you need and you leading the way and how you're going to get better. So in many ways, this model is a self-directed model. It's important to define what a peer respite is. And Leisha led a consensus panel of people with expert and research training advocacy for peer respites, people who operate peer respites, and they and came to these three criteria. As I mentioned, 100% of the staff are themselves peers. They're people with their own personal lived experience. The leadership, so the program manager, program director, are also peers. And the job description for those positions requires lived experience. And then there's peer governance. So it's either operated by a peer-run organization, or the peer respite may be operated or have an umbrella organization that is not peer-run, say a provider organization or a community organization, but the peer respite has an advisory group that is majority people with lived experience. So there's a real emphasis here on the lived experience piece. That's really one of the key ingredients. So, as I mentioned, peer respites have been proliferating year after year in the peer respite essential feature survey. We've gone from 10 peer respites in the country in 2012 to 31 in 2018, which was the last survey. And you can see where they're at throughout the country. And then I'll say a bit more about the research, and then again, I will hand this over to the people with the actual vital lived experience of working at a peer respite. The second story, Santa Cruz peer respite that I mentioned earlier, is one of the most studied peer respites. We had an evaluation, and the program itself was funded by a mental health transformation grant from the Substance Abuse and Mental Health Services Administration back in 2015. And so through that work, that funding, we were able to really implement a mixed methods evaluation, and we looked at the guest experiences, and then we also looked at some service use data from the county to see if people who used the respite were more or less likely to use inpatient or emergency services than a comparison group of people who didn't use the respite. And we did find that people who used the respite were 70% less likely to use inpatient or emergency services compared to a group of people with similar characteristics who did not use the respite during the same time period. We also found that when people who had used the peer respite did end up in the inpatient and emergency services at some point later, they left sooner. So if they used inpatient emergency services, they used fewer of them, fewer hours. Earlier, before Santa Cruz, there was an additional randomized controlled trial that looked at costs, and they were similar to the findings that we presented in Santa Cruz. And so Greenfield, Stone King, and colleagues, they saw improvements in healing, empowerment, satisfaction in surveys for respite users compared to non-respite users. And average psychiatric hospital costs were a couple thousand lower during the study period for respite guests compared with non-guests. And then more recently, a peer staffed respite program in New York City was evaluated. And so it's doesn't meet all three of the criteria for peer respites, but very similar, and staffed by peers. And they also had an evaluation that found monthly Medicaid costs were significantly lower, over $2,000 lower, and that there were about 3 fewer hospitalizations for people who use respite. So a good body of evidence this theory that respites keep people from needing to use the hospital and provide an alternative seems to be bearing out in these studies. And pardon the children in the background. I'll speak a bit more to what we learned from speaking with peer respite guests. These are the themes that we uncovered in looking at the transcripts of the interviews that we did with 30 interviews with people who used the respite. When we asked them what was it like, how did it compare to the hospital, what worked, what didn't work. And these, I'm just looking at the questions. These data were collected between, I believe, 2014 and 2017. I might be a year off on that. Anyway, we heard these are the themes that emerged. So themes that were common across interviews that seemed to come out when we looked at the words that people said. One is that the respite provided a sense of belonging to a peer community, and that gave a lot of people that belongingness helped people along in the recovery, that the respite fostered confidence and hope that they could self-manage their crisis, that they could reach out and use the resources available in the community when they were experiencing crisis, and that that then helped to not need sort of more disruptive or coercive interventions like an emergency room. We heard a lot about mutual support and the importance of mutual support. Intentional peer support was the training model that was used for the staff in this respite, and that really made an impact on a lot of the staff and the guests. This experience of mutuality that was quite different than what they'd experienced from traditional clinicians and in more traditional medical settings. The respite seemed to function as a linkage to the community for a lot of people. So people got linked up to other community groups, other supports. And finally, there was an element of conflict and confrontation that I don't think I'll have time to get into here, but basically the mode of mutual support that was practiced really involved people looking at each other and looking at relationships in a direct way that was experienced as healing and transformative for some, and then others not so much. So that's all outlined in that paper, and I will close, I believe, with one last quote. And it is, I felt like I kind of joined this temporary family, and I realized I didn't need to be locked in. I just needed people around me so they could talk when I needed to, and they could just kind of surround me with love and support. So I feel like that sort of encapsulates a lot of the themes. One last slide before I hand things over to Casey. In terms of what's next for research, I think there is more to do. We need to have, I think, stronger and more documentation of really whether and how peer respites reduce costs in particular, because I think that really helps systems to determine, whether this impacts the bottom line and could make a big difference in terms of uptake and increase of peer respites. But also what other outcomes does this improve? In terms of the program level, there's still a lot to do about developing, what you might call fidelity to peer respite. So what is it about peer respites that produces the outcomes that we want, and how do we make sure that is retained when more and more peer respites are opened? And then finally, on the system level, how do peer respites fit in the service system? How should referrals work? And what impact might they have on other services in the system in terms of transforming a system, maybe to be more person-centered, maybe to promote more self-management and less, kind of medicalization of social challenges that many people might be experiencing. So a lot to do, and it's an exciting field to be exploring. So thanks for letting me share my research with you. I have a list of research here, and this is also on the brief that you'll be able to download after this webinar. And now I'll turn things over to Casey.
Good afternoon, everyone. I'm going to go ahead and talk about what I call is a very unique collaboration. It starts with all of us we are the Mental Health Association of Nebraska. We started out in 2001 with 2 staff, myself and 1 other, and we have grown tremendously in the last few years. I just want to point out that, we are completely peer-run. Every person in this picture has a history of mental health, substance use, trauma, maybe incarceration. We've got a vast variety of experiences here. And also, we're very intentional on the diversity of our organization. I want to point out that, 33% of us identify as people in the LGBTQ community. 34% of my staff identify as not white. 23% experience voices. 11%, I like to talk about this, have worked their way off of Social Security benefits. And about 36% of my staff have a history of incarceration or a felony background. It's really important, like I said, for us to be diverse. But I don't intentionally hook people up with, like, if you're working with somebody with a mental health issue, they have to have a mental health issue, or substance use, people with peers with substance use disorders have to work with other people who are dealing with substance use. For instance, I have veterans who come in. Some of them want to speak to the other veterans. Some of them do not. So they will connect with who they connect with. This is a police captain who thought it would be funny to put this in our slides because everybody outside of Nebraska, I think, thinks we are pretty rural. And he wanted to show that we actually have a town here with a pretty good sized stadium and have a community. We don't all live in the cornfield. So this is our Kia house. Kia house has been around since 2008, and it is a 5-day stay typically. However, we do work with the other community partners. So if somebody comes in and they want to, they're trying to get into treatment or they're trying to get into another facility, oftentimes what would happen is when their name came up on the list to get the treatment bed, we couldn't find them, they were using again. So if they have a plan, we will work with other community partners to allow them to stay at Kia long enough to get the services that they need. You have to be 19 years of age or older, adult, 19 because 19 is legal age in Nebraska. We've had a lot of guests stay at Kia. We've never had an incident at Kia, which I like to talk about. You can see there in 2019, we had 7 police calls for service. The law enforcement in Lincoln are one of our greatest supports. They are very aware of all of our services, and I'll talk about that a little later. This is another respite home that we run. This is we call Hanu home. It is a transitional, more type home for people coming out of our state correctional system. What we learned was that a lot of people, as you all probably know, are ending up, people with mental health and substance use issues are ending up in our correctional facilities. So we wanted to be able to serve that population. And we were able to open up there's 20 beds in this home and 14 bathrooms. And the average stay is about 90 days. So we have a peer meet them when they are coming out of the correctional facility, and then we assist them in getting their basic needs met. And then we work with them on, supporting them in employment and getting back into the community and building some of those community healthy relationships. So I just want to point out there, too, with 20 individuals coming out of a state correctional facility, on average, we serve about 117 people a year in this home. And in 2019, we had 26 calls for service. So our goal is to really be an asset to the community and not become a sore spot. This is the rooms in our Hanu home. We take pride in making sure people have a safe, comfortable place to be. A lot of times when they come into our home, they've never had a safe, clean environment. A lot of them have never had a bed before. They will come in and they'll cry when they see their room, and everybody said that with the population that we serve, that these rooms would be destroyed right away. And there were a lot of negative comments, and they still look like this, and people really respect the house, and it's a beautiful place to be. What's cool about this is we didn't buy all this for these rooms. The community put them together for us. So like parole administration all got together and put a room together for us. A physician's office put one together for us. The State Department got a team together and put together a room. So it was a really cool experience to have the community involved in. A lot of times people talk about not in our backyard. We are not going to have a respite in our neighborhood. And one of the things I'm most proud of is our houses are very accepted in the neighborhoods. Not only are they accepted, but that we work a lot together. In these pictures, I'm showing you the assisted living that is just to the south of us with elderly people living there. And so we have a home, like I said, with 20 people who have just come out of the state correctional facility with severe mental health and substance use next to an assisted living, and we are great partners. In this picture, the assisted living bought us all a bunch of like $200 worth of fireworks so we could have an event with both places and have a 4th of July event together. I just think it's awesome. We belong to the neighborhood association. Our peers attend the neighborhood association meetings. We get involved in all the neighborhood events, and it's really broke down the stigma to the point where when we go in front of the city planning department for our zoning, both houses have been unanimously voted on as getting the operating permits. Sorry. This one I showed, so the last one I showed you was Hanu Home. This is Kia House, and the neighborhood association actually advertises us on their website as a positive thing in their neighborhood. It became really important for us to, again, the community inclusion is so important, and so we recently started sponsoring our kickball, softball teams, and how this is unique is it's not only the staff and the guests of our services, but it's also, you can see here, correction officers playing kickball with the people that have been incarcerated before. So it was just really unique to get everybody together and see people from a different perspective. And I can't express enough how much the stigma with law enforcement and correction officers and our peers and how they view those folks, how much that's changed. We are very involved in educating our Lincoln Police on our respite services and all our peer services. So here you can see new recruits on the porch of Kia. They all in-service training, dispatch, new recruits. We are involved in that. We talk about what it's like for us to come in contact with police officers, what's helpful, what's not, how they might be able to distinguish somebody between who's dealing with a mental health or substance use issue versus someone who's a threat. We've been doing that for 11 years now, and it's very strong. And actually, we just started working with the Sheriff's Department as well. I want to talk a little bit about how COVID has affected all of this. Yes, we do have a warm line at both houses. I will tell you that if you open up a respite, often if it has a phone, you now have a warm line. So we've done a lot of training on those, and those calls have increased by about 35% since COVID has hit. It's been, we've tried to address it by adding additional peers, and I think that we average about 300-400 calls a month at Kia and about 200-300 a month at Hanu Home. On average, we were receiving 4 to 5 referrals a week from law enforcement. That's another program, but they work really closely with us, and since COVID, those have definitely gone up. And we are now having people complete COVID screening and trying to protect our staff and guests. But of course, people that are coming to Hanu, coming out of prison, they're being released no matter what. So we are trying to do all we can to keep people safe and wear masks and take temperatures. And so far, we haven't had any cases, but the cases in Nebraska are also increasing. It definitely has had an impact on my peers. We have really struggled with our own mental health and being isolated, and the substance use has definitely increased. We have worked on our own RAP plans and shared them with our coworkers, and really trying to, support each other through this. And at the same time, the calls for service and people wanting to come in for services have increased. So as it has had an impact on our own wellness, and then you add the increased demand for services, it has been a bit challenging. And that's just a little bit about our services and our peer respites in Nebraska. And I'll go ahead and turn it over to Dr. Vincent.
Hi, everyone. Thank you for having me today. So I'm going to talk a little bit about, again, some of the things that Bevan covered about different types of respite, and that Casey covered about some barriers. But then I'm going to really talk about respites during and post COVID-19 and some of the things that, lessons that we've learned and things that we will be using moving forward. So I run 2 short-term crisis respites. So one is in a very urban area, one is in a very rural area. They are non-clinical, peer-run. I run a peer-run agency. We have about a 5 to 7 day stay on average. And really it's a time to just seek and receive 24/7 peer support in a safe, non-judgmental environment. We are in the process of opening an intensive crisis respite, which has all of the same features as a short-term crisis respite. It is still completely peer-run. The average length of stay, that's the type of it, is actually 14 days. And on site there's access to a nurse, counselor, and a psychiatrist. And although those services are not mandated, they are available for anybody who would like them. Both of these programs are self-referral programs. So all someone has to do is call us and say, we're struggling with something, and they can come on in and stay with us, although other people can refer them to the services if they would like to. We feel that as a peer-run agency, that having a program that is run by peers on every level really provides that nurturing environment for people to come in and feel safe, with our shared experience paradigm that we all operate under. We lead the way with our lived experience. We want to make our environment as comforting to people so that they know that they can come in and they can share with us, and that it's a much more calming space. When we went to open our respites, we had a very large uphill battle that we had to deal with, because in our area, both in the setting that's a little bit more urban and then the setting that's more rural, this was not a known commodity. People really didn't understand what we meant when we said we were opening a peer-run respite. So we looked for sites that identified the needs of our program. Space in the house, certainly. Backyard space in our urban setting, that was very important to us. In our rural setting, having a little bit of space between neighbors was very important to us. We wanted a location that felt like a home, because that's what our respite is. It's a home where you can come to and stay and just know that you're safe. Identifying a site in an area with community support was challenging. We initially dealt a lot with, like I said, businesses, neighborhoods, zoning boards, people, that didn't really understand who we were. So we had to do a lot of community education, town hall meetings, going, door to door to businesses, working with the local government, and we were trying to really identify what the fears were for people as we were talking about bringing this program in. A lot of things we heard was that people didn't really understand what the program was for. If we were bringing people in who had mental health issues or substance use disorders, was it going to be safe? Is this something that they really wanted in their town? And we went to several zoning boards. We identified several sites. We got turned down several times before we found communities that were really willing to embrace us and work with us. And now they absolutely love us. I have to agree with Casey. You know, I've told people we are really the best neighbor that you can have. Our staff is always there because we're open 24/7, so there's always a presence in the house. We, you know, let people know that this is a great place to come, but for the neighborhood as well, it's a great place to really give back to the community and interact with people. We will have neighbors come over and have meals with us now. We have different organizations in the neighborhood. They'll make us blankets for beds. They donate food to the respite. But really it was going out, holding those neighborhood meetings, and just really sitting down and having honest conversations. We give tours of our respite to anybody that would like to come in, as long as we have permission of our guests who are there. Let them come in, let them see it is really a home. It is non-clinical, and we really try to be as transparent as we can be about what it is that we are doing to support people. I pulled a few quotes. We have a thank you notebook. People leave us notes all the time just expressing how much they've enjoyed their stay. So I pulled some from these books. People are just very happy. The environment is very caring, understanding, very friendly. They want us to know that, you know, this program has helped tremendously, both mentally and physically. Without a doubt, the most incredible part of the journey was the manner in which everybody gave so freely of themselves, sharing your journey with just enough to validate thoughts, fears, and concerns. You know, again, sharing with a purpose. Someone wrote, I thought I was just here to have a place to stay and have a roof over my head, but boy, was I wrong. I got so much more. You've helped me heal and want to move forward in life. A lot of what we do in our respites is work on things like RAP plans, action plans. What is it that we are going, you know, to do moving forward? You know, taking whatever was going on in a person's life with whatever brought them to the respite and putting, you know, helping them put order and a plan to things so that they feel more confident that when they leave. And then our respite provides services at post-discharge at 30, 60, 90, and 180 days, where we initiate either a video phone call or a telephone call just to have a conversation and see how people are doing. And then guests are welcome to call us anytime. And it is true, if you do not have an official warm line in your respite, once you open, you will have a version of a warm line. A lot of our former guests, they call, they like to chat with staff that saw them and worked with them while they were there. They just like to call for support sometimes. So most respites I know of have a version of a warm line. Ours also have a text line, and we have a virtual line. Our virtual line's been open for about a year and a half, and it is basically a virtual warm line. So people will call in, ask to do a virtual session with someone. We set them up in an online room where they can just have some face-to-face peer support with someone, usually anywhere from half an hour to an hour, although they are welcome to stay on the line longer if they'd like. We started it because the one area that we have a respite in is really, really rural. I live in a town that's so small it has no stoplights in it. So when I say rural, it's a lot of farm country, and a lot of people don't have access to services. And have, the distance is challenging for them. And even though we have vans for our respites and we do help transport people, sometimes the distance is just something that people don't want to initially travel. So we also use our virtual line to give virtual tours of our respite and to allow people who are calling in to meet staff, so that if they do want to come and stay at the respite, they've seen the house, they've seen staff, they've been able to have conversations with staff, and that really helps people feel much happier and more confident about coming to stay with us. COVID-19 was a challenge for all of us. So of what we discovered with our respites is that, first of all, the county governments where our respites are located asked us to stay open. So we never closed during COVID, which initially was very scary for my staff because they were scared of exposure. Would they be taking something home to their families? Were they putting their physical health at risk? But we did a lot of talk and education sessions with them, and they did such a great job. We kept the respites open. Our warm lines, which had not traditionally been open 24 hours a day, we made available 24 hours a day, and we will be keeping them. At that time frame, our calls have over doubled since the beginning of COVID. We're averaging about 250 to 300 calls per respite per month pre-COVID. During COVID and continuing now, we are at over 1,000 calls a month per respite, as well as the text line and the virtual line. Those numbers have increased as well. Initially, we didn't have a lot of guests coming to the respite during COVID. It took us a few weeks to, talk to people about the precautions that we were using, the safety features that we had put into place. But, we were eventually able to, help people understand that we really were going to do everything we could to keep everybody safe. So I found this quote from one of our guests very compelling. They were scared to come here with the virus and all, but was more afraid to go to the hospital. I made the right choice for me. The staff helped me feel safe and talked to me about my fears. They even helped me learn how to use Zoom on my phone so I could start going to groups again. So one of the things that we learned and implemented quickly was that while some people have tech, they don't always know how to use it for these particular programs, Zoom, Skype, WebEx, GoToMeeting. So we were able to help people either virtually on a virtual line or on a warm line, or that came into the respite, learn how to utilize some of those programs that they just didn't have any experience with, so that they could go to virtual groups. They could do face-to-face conversations with families. They could do telehealth with other providers, and that really helped support people to maintain the services that they wanted and to stay connected to people and to help avoid a lot of the social isolation that many of us have dealt with. And one of the greatest lessons we've taken from all of this is how to prepare for, hopefully never have to prepare for another pandemic, but if we do, how to very quickly work with the community in order to make sure that we are a source of comfort for the people that we serve. And I would like to thank you all for listening to me. I appreciate it. And with that, I'm going to hand it back over to Dan.
Well, thank you. There were a lot of questions in the chat box, but also comments with words like amazing, and awesome. The work that I think how quickly and which demonstrates the passion and commitment of your work, is how you quickly transitioned. And I'm sure it wasn't easy to be able to adapt during a pandemic. It was frightening for everybody, but I think at the street level and the trenches where you are, I think I really want to commend both of you and your staff for the work you're doing at this point in time. So before we still have some time to address some of the questions in the chat box. Am I correct, Julie?
Yep, we could take it right to the end.
Yeah. Okay. So let's start doing that, and then we can talk about the other logistics and transitioning over. Bevan, there were a couple high achievers and participants who already went to the website that you mentioned. That's a resource directory. And do you want to make a couple comments about that so everybody's on the same page about that directory?
Yeah, I should have specified earlier. The directory, as with all directories, it requires sort of staff time and to maintain and make sure that it's up to date. And there was and is no funding to do that for any organizations that are maintaining the website. But we still thought that it was important to keep the site up because the resources are still timely and valuable. So the resources are still there and free to use. And I can't speak to which of the individual programs are still operating and what their individual characteristics are. But at least the directory is current as of 2019. So hopefully you'd be able to track something down if you were interested in learning more.
Okay, thank you, Bevan. So one of the questions occurred early on in the presentation, but I think it could be addressed by all three of you. There's a question about the length of stay. It seems to be relatively short, somewhere between 3 and 7 days, I think. In peer respites, and I'm wondering what, Bevan, one from your experience nationally, whether that is just the average capacity, that the length of stay rather that you find, and to Casey and Kirsten after how your length of stay is arrived at. So Bevan, why don't you start?
Yeah, I can start. So it would definitely be good to hear from Kelly and Casey on kind of what their length of stay is and what the rationale is. In I can look at my slides. That we have in the Peer Respite Essential Features Survey, we have the average length of stay and the range of length of stay, so you can see exactly what it is. Let's see if I can quickly pull it up. I can't, but it's in there, and it's on the first slide. But I can say too, just conceptually, 2 weeks. These are meant to be short-term stays. These are meant to be a place where you can come and take a break, get back on your feet, get some support, figure out where you want to go next, and then move on. So, they're really designed to be short stay. And not to be something that people stay for months and months, and also not to be something where you only stay for a day, because it does take some time for those relationships to get built, and for people to just detach and calm down from whatever they were experiencing before. But I'd like to hear from the other folks about what their length of stay is and why.
So this is Casey, and ours is basically 5 days. We only have our Kia house is 4-bedroom, and I think the whole goal of peer support is for individuals to find their own wellness and their own strength, and to take control over their own life. And so the goal is to not create another dependent relationship. I think a lot of us have gotten stuck in systems. So again, the goal is for them to create plans and be self-aware and be in the community and not end up stuck at a respite house or in the behavioral health system. That being said, of course, there are circumstances. Life happens, events happen. We had one individual who had utilized the hospital emergency room 32 times in 1 year. And so, of course, we went slower with her, and we gave her the opportunity to, try going 7 days, try going 8 days before coming back. So it's very individualized. But I really strongly believe that if we are holding true to the peer support model, we're encouraging people to be in charge of their own wellness and not get stuck in a system.
Hi, it's Kristen,
Thank you,
and I would,
Yep.
yeah, I would agree, and I would echo that. Our average length of stay is 5 days. Day of arrival is day 0, and I mean some people will stay 3. I will extend a stay up to 7 days if the situation, really would, if the person would really benefit from having the extra days, but we like to keep it right around 5. For that same reason, I think that people, go to the emergency room or have gone to the emergency room in the past because it's what you know. So, trying to break that cycle, we don't want to create a new cycle. So that's why we focus on community linkages, and different in the community opportunities when someone is staying with us in addition to our peer support, so that we can just try and help, foster those natural supports in a positive way. And then our general rule is somebody has to be 30 days in between stays. They are allowed to come, more than once a year. But if we see that somebody wants to utilize the respite more, then we'll build that into their goals and their wraps to try and, put more time in between respite stays, and work more with us on, again, creating those natural resources.
Yeah. Okay. So, trying to balance individual need against encouraging independence and self-direction. So, there's one question about the difference between peer respite and crisis stabilization units. I think one of the clear differences is that the crisis stabilization units are generally staffed by medical professionals, so maybe peers involved in those programs. They're relatively short-term stays, and but there's a primary medical component with the stabilization units, that peer respite, which is more of a home-based, fully peer support model. They operate more on that model. But the one thing I did want to ask you about, related to that, Kirsten, is that intensive crisis residence, peer or respite residence that you spoke about. That seems to be a little bit of a nuanced kind of approach that I hadn't seen before. So are those reach-in services or on-site services?
Those are on-site services. The nurse, there's always a nurse on duty, and then there is the availability to have a on-call counselor and an on-call psychiatrist, and that availability is 24/7, but they are not on site. Most of that is done through telehealth, although there are on-site visits during what we would you would call normal business hours, and it is definitely it's intensive because the length of stay is longer. It's up to 14 days, but it's also for people who are not sure that a short-term respite is right for them, but still really don't need a hospital stay. So it's kind of trying to balance that in between for them as well.
Thanks. And did that require licensing of any kind, where were there those kinds of issues you had to deal with for that model or not?
So in New York, it is a licensed OMH program. There we go. It's a licensed OMH program, but it's still peer run. So
right.
Even though there's a medical component, it can be still purely a peer run. A non-peer agency can open an intensive crisis respite, but peer agencies are allowed to do it.
Okay. Well, that's helpful. And there might be more discussion about that when we get to our discussion group, which will be coming up soon. I do want to just ask one last question because we're almost to the top of the hour. You both did a really nice job talking about the not my backyard issues and whining and dining the community, right? To educate them. I like your billboard sign that about awareness and educating people so that they're curious about programs and then want to be part of the solution. So can you talk a little bit more about that? Who are key people in a community to address? Is it the zoning boards? Is it the town mayors? How do you build the partnerships to get programs cited and implemented? So, Casey, why don't we start with you, and then we'll go to Kirsten.
Yeah, so when we opened up, Kia was the first house that we opened up, and we were very intentional about how we were going to go about it. We actually had peers go door to door with the neighbors. Like I said, we were involved with the neighborhood association right away. And yeah, we also had conversations with city council, the planning department, the mayor's office. We wanted mostly to be able to hear out what people's fears were and then address them. One of the biggest fears was calls for service for police and the property value going down. And so one of the things that we did was have law enforcement involved, and they went and with me to talk to neighbors and to the folks who had concerns. And specifically with Hanu, their biggest fear was the sex offender population. And so we had law enforcement show the sex offender registry already of the number of people in their neighborhood. So it was really educating people, also breaking the stigma, like I said, and having law enforcement talk about how mental illness is not dangerousness, doesn't equivalent to that. So it was really helpful for us to have our key partners in addressing those with the neighbors.
Thank you, Casey and Kirsten.
Similarly, I would say that the first site we went to, we did it all wrong, learned a lot. We engaged with our neighbors, our first just to talk to them, explain the programs, worked with local law enforcement, small businesses. So, that the business arena was on board as well. We are partially funded by the counties that the respites are in. So being able to take a partner from the county and from the Office of Mental Health to meet with people was extremely helpful. And law enforcement, I would have to really agree with Casey, being able to engage with law enforcement and have them have great community talks with neighbors really helped us be very successful.
Okay, thank you, Kirsten. On that note, we're at the top of the hour. We're going to transition to our discussion group. But before we do, the document that was, go back one slide, Julie. The document Peer Respites in the United States, authored by Dr. Croft, is available for download. You can select the download, the file on your screen, and you can download it to your computer. Okay, and now the directions for the discussion group are below. Please select the Adobe Connect link and then dial back in. We'll resume, and it should take a couple, 3 minutes for people to get back online. So that goes for our panelists also. We'll have to dial back in. Thank you very much. Thank you to the panelists. This was a wonderful discussion. We had a lot of interest in our chat box and among the participants. Talk to you again in a few minutes. Thank you. Bye-bye.